Welcome to the deep dive. Today, we're embarking on a really fascinating journey. We're going deep into something that literally fuels us every single day, our primary digestive organs.
That's right.
It's truly incredible how complex, how resilient the system is. But what happens when things don't quite go as planned?
Exactly. There can be issues.
We're going to pull back the curtain on some of the most common and really impactful conditions that can affect this vital part of our body. You might find some surprising connections.
Absolutely. Our goal today is to explore quite a range of conditions, starting right up top with the esophagus, then moving through the stomach, the intestines.
Even the appendix.
Even the appendix, yeah.
Mm.
And you might think of these as, separate problems, but understanding them really gives you a deeper appreciation for the intricate choreography happening inside you. It highlights how connected digestive health is to everything else.
Okay, let's kick things off. A condition many people have heard of, peptic ulcer disease, or PUD.
PU, yes.
So when we talk about PUD, we mean open sores, right? Erosions in the lining of your stomach or the duodenum.
Yeah, exactly, the duodenum, that first part of your small intestine. And they can be short-lived acute ulcers or more persistent, deeper ones we call chronic.
Now, here's something crucial. For a long time, everyone blamed stress, spicy food.
Right, the usual suspects.
But the most common culprit, and this really changed things, didn't it? It's actually a bacterial infection, H. pylori.
That discovery of H. pylori, it completely revolutionized how we treat ulcers. But beyond that, there are other risk factors too.
Like what?
Well, long-term use of certain meds like NSAIDs, ibuprofen, naproxen, corticosteroids too.
Ah, okay.
And lifestyle definitely plays a part. Too much caffeine, alcohol, smoking. And yes, chronic stress can still contribute.
Interesting. And I heard the location can vary with age.
It often does. Duodenal ulcers, they're more common overall. You typically see them in the 25 to 45 age group.
Okay.
Gastric ulcers, the stomach ones, tend to show up a bit later, maybe 55 plus.
So if the location is different, does the pain feel different too? That seems really important for someone trying to figure out what's going on.
Absolutely critical distinction. With gastric ulcers, the pain often starts, say, 30 to 60 minutes after eating.
Pretty quick then.
Yeah, and it's usually high up in the central abdomen, the epigastric area. You might get nausea, maybe vomiting. Pain can be worse at night. And here's the tricky bit. Sometimes eating might actually relieve it.
Okay. Might relieve it. And duodenal ulcers.
That's different. Pain typically shows up 2 to 3 hours after eating. Same area, epigastric, maybe radiating to the back.
Yeah.
But the key sign here, pain is often relieved by eating or taking antacids.
Ah, relief with food. That's a big clue.
Huge clue. And this pain is notorious for waking people up at night. Diagnosis usually involves an endoscopy, a camera
Right.
and specific tests for that H. pylori bacteria we mentioned.
And once you have a diagnosis, what's the plan? How do you heal these?
Well, in an acute setting, like in the hospital, the priority is often rest for the gut. So NPO, nothing by mouth.
Complete rest. Yeah.
Exactly. Supported by IV fluids, of course. If H. pylori is confirmed, the standard treatment is often called triple therapy.
Triple therapy?
Yeah, it's a combo. 2 antibiotics, usually clarithromycin, amoxicillin, plus a PPI, a proton pump inhibitor to slash stomach acid.
Got it.
Other meds help too, like histamine receptor blockers, famotidine, which most people know is Pepcid, and just regular antacids for symptom relief.
It sounds like a careful management process.
Yeah.
But what if it goes really wrong? What are the big dangers?
Yeah, the complications can be serious. We worry about significant bleeding or something called gastric outlet obstruction, where the ulcer blocks food from leaving the stomach.
Okay.
But the most critical one is perforation. That's when the ulcer literally burns right through the stomach or intestinal wall.
Wow. Creates a hole.
Creates a hole, yeah. And when that happens, stomach contents leak into the abdomen. The belly can become rigid and hard, and the risk of sepsis, a massive body-wide infection, becomes very, very high. It's life-threatening.
That is incredibly serious. So for someone managing PUD, what are the absolute must-dos to stay safe?
Number 1, take your medications exactly as prescribed. Consistency is everything.
Right.
Number 2, learn your trigger foods and avoid them. And this is really, really important. You need to stop taking aspirin or NSAIDs for about 4 to 6 weeks while that ulcer heals.
Okay, no ibuprofen then.
Definitely not. It can make things much worse. And finally, always report any new or worsening signs to your healthcare provider immediately. Increased pain, any blood in your stool, don't delay.
That's crystal clear. Okay, let's shift gears. Another super common issue, GERD gastroesophageal reflux disease. Many people just call it heartburn, right?
That's a common term, yeah.
Hmm.
Essentially, it's stomach acid or sometimes duodenal contents flowing back up into the esophagus.
And why does that happen?
Usually because the muscle at the bottom of the esophagus, the lower esophageal sphincter, isn't closing properly. It's like a faulty valve. We call it incompetent.
Gotcha. And what makes it more likely?
Common risk factors include things like alcohol, smoking, being overweight, pregnancy, and certain foods, particularly acidic or spicy ones, can trigger it too.
So if you're dealing with GERD, what are the first things you can try? What really works?
Lifestyle changes can be surprisingly powerful. Two big ones. First, avoid eating or drinking anything within 2 hours of bedtime. Give your stomach a chance to empty.
Makes sense.
Second, elevate the head of your bed by 4 to 6 inches at night, just using blocks under the bedposts. Gravity helps keep the acid down.
Simple but effective. What about medications?
Antacids give quick, temporary relief. For more persistent issues, there are PPIs, proton pump inhibitors, which are very effective at reducing acid production. And also histamine receptor blockers, like that famotidine peptide we mentioned earlier.
Now, I've heard some concerns about using PPIs long-term. Is that something people should know?
Yes, definitely something to discuss with your doctor. Long-term use of PPIs has been linked to an increased risk of osteoporosis, so weaker bones.
Good to know. And GERD itself, can it cause other problems if it's not managed?
It can. Chronic acid exposure can lead to Barrett's esophagus, which is a change in the esophageal lining that increases cancer risk down the line, and even dental problems from the acid. And an interesting point, older adults sometimes perceive GERD pain differently. It might feel like angina, like chest pain from the heart.
So it could be mistaken for a heart attack.
It can be, which makes getting the right diagnosis really important. On a brighter note, many kids with GERD actually outgrow it.
Okay. Let's move to conditions we see much earlier in life. Cleft lip and palate. That's something present at birth.
Right. It's a congenital abnormality. It happens when the lip or the roof of the mouth, the palate, doesn't close completely during development in the womb.
And what are the signs you look for in a newborn?
Well, the most immediate issue is often difficulty feeding. Getting a good latch can be tough. But you also look for chronic ear infections, potential speech issues later on, maybe hearing impairment, and sometimes even problems with breathing, airway obstruction.
So what's the priority for care, especially early on?
Education for the parents is huge. They need to learn how to use special nipples for feeding, which are designed to help the baby feed effectively despite the cleft.
Right.
And then, after surgical repair, a key instruction is for the infant to sleep on their side. This helps protect that suture line, the repair site.
Okay, side sleeping post-op. Got it. Now here's one with a very specific sign. Pyloric stenosis. What's happening there?
Pyloric stenosis is a narrowing of the channel between the stomach and the small intestine, the duodenum. That muscle, the pylorus, gets thickened.
So food can't get through properly.
Exactly. It blocks the passage of food. And the main sign, the really characteristic one, is projectile vomiting. As that narrowing gets worse, the vomiting becomes incredibly forceful.
Projectile vomiting. That's unique.
Very unique. Another specific finding is sometimes you can actually feel an olive-shaped lump near the belly button during an exam. That's the thickened muscle. And of course, because they can't keep food down, these babies are persistently hungry but fail to gain weight.
Sounds distressing. What are the key interventions?
Well, surgery is needed to fix the narrowed muscle. Before that, maybe an NG tube to empty the stomach.
Right.
Afterwards, the absolute rule is NPO until feedings are specifically ordered by the surgeon.
Okay.
Then feedings start very slowly, small amounts. And for discharge, parents need clear instructions. Definitely report to the healthcare provider if the baby gets a fever over 101.3 degrees Fafatorial or starts vomiting again after they've begun clear liquids.
Crucial follow-up. Okay, let's move down the track again. Bowel obstruction. That sounds bad.
It can be very serious. It's just what it sounds like.
Right.
A blockage in the small or large bowel.
And there are different types.
Right. We talk about mechanical obstructions where there's a physical block, maybe scar tissue, what we call adhesions or a hernia,
Okay.
and non-mechanical obstructions where the problem isn't a physical blockage, but the bowel itself isn't moving properly. Issues with peristalsis, those muscle contractions.
And does it matter if it's the small or large bowel?
Oh, definitely.
Yeah.
With a small bowel obstruction, the big immediate risk is dehydration. Fluids just can't get absorbed properly. The symptoms are often quite dramatic. Sudden onset of really intense, crampy, colicky, wave-like pain. You might see mucus or blood, but importantly, no actual fecal matter is passing. And in severe cases, you can even get fecal vomiting.
Fecal vomiting. Wow. How is that managed?
Often requires an NG tube to decompress the bowel, and definitely IV fluids for that dehydration risk.
And large bowel obstruction.
That tends to present more gradually. Maybe chronic constipation, weakness, losing weight. Noticing the shape of the stool has changed.
Got it. And the bottom line for either?
Simple. Report any symptoms that suggest a bowel obstruction to your healthcare provider immediately. Don't wait.
Absolutely. Now let's talk about that sudden, sharp pain appendicitis, inflammation of the appendix, right? That little pouch off the large intestine.
Exactly. And the critical thing here is that if the opening, the lumen, gets obstructed, it can swell up, get infected, and potentially perforate burst.
Leading to?
Peritonitis, a dangerous infection of the abdominal cavity. That's the major complication we want to avoid.
What does appendicitis typically feel like?
The classic story is pain starting as a dull ache around the belly button, then it moves and sharpens in the right lower quadrant, RLQ.
Okay, RLQ.
Yeah. And it usually gets worse with movement, walking, even coughing. There's often tenderness at a specific spot called McBurney's point on that lower right side.
And if you suspect it, what's the immediate plan?
Priority is maintain NPO status until surgery is done. No food or drink. Start 4 fluids. Give antibiotics.
Right.
And here's a massive warning. Absolutely never apply heat to the right lower abdomen. No heating pads.
Why not?
It can increase inflammation and blood flow, potentially causing the appendix to rupture much faster. Really dangerous.
Wow. That's a vital piece of safety info. Okay, let's switch to celiac disease. This is an autoimmune thing, right? Related to gluten.
Precisely. It's an autoimmune disorder where eating gluten, that protein in wheat, rye, barley, triggers an immune attack on the person's own small intestine.
And that causes damage.
Yes, significant damage. The gluten triggers inflammation that destroys the microvilli. Those tiny little finger-like things lining the intestine that absorb nutrients.
So you can't absorb food properly?
Exactly. The surface area for absorption gets drastically reduced. Symptoms often include bloating, diarrhea, fatty stools called steatorrhea, but also wider systemic issues because of the poor nutrient absorption, like anemia or vitamin deficiencies.
How is it diagnosed? I heard something specific about testing.
Yes, this is critical. It's incredibly important for the client to continue eating gluten throughout the diagnostic process.
Really? Keep eating the thing that causes the problem.
Yes, because stopping gluten too soon can allow the intestine to start healing, which means the blood tests and biopsy might come back looking normal or less inflamed, leading to a misdiagnosis. You need the inflammation to be present to confirm it.
That makes sense. And the treatment, is there a medication?
This is another crucial point. There are absolutely no drugs on the market currently that can induce remission for celiac disease. 0.
So what is the treatment?
The only effective treatment is a strict, lifelong commitment to refraining from any exposure to gluten. That means checking all foods, labels, even non-food products sometimes. No wheat, rye, barley, and often certain oats need to be certified gluten-free.
Wow, lifelong vigilance. What about a celiac crisis?
In a severe flare-up or crisis, the priority is NPO status and aggressive IV fluid and electrolyte replacement to manage severe dehydration and imbalances.
Okay. Let's move on to inflammatory bowel disease, IBD. This is different from IBS, right?
Very different, yes. IBD refers to chronic conditions involving actual inflammation or ulceration in the bowel. IBS, irritable bowel syndrome, is more about bowel function and sensitivity without that underlying chronic inflammation. Big difference.
Got it. What puts someone at risk for IBD?
Genetics definitely play a role. Having a family history increases risk. Smoking is a known factor, particularly for Crohn's disease. And interestingly, NSAID use might also contribute or worsen flares.
How do you diagnose IBD?
Blood tests often show signs of inflammation during a flare, like an elevated erythrocyte sedimentation rate, ESR, or C-reactive protein, CRP.
Okay.
But the gold standard, really, is a colonoscopy. And crucially, taking a biopsy during the colonoscopy is essential to confirm the diagnosis and also to help differentiate between the two main types of IBD,
Which are?
Crohn's disease and ulcerative colitis.
Right. And are the treatments similar?
There's some overlap. Medications like aminosalicylates help reduce inflammation. Immunosuppressants are often used, like 6-mercaptopurine or 6-MP, although there's a key point. 6-MP should not be given when the disease is acutely active.
Important distinction.
Yes. Antidiarrheals like loperamide help manage symptoms. Non-drug approaches include finding an individualized diet that works for the person, avoiding triggers like cold foods, and definitely quitting smoking.
Okay, let's break down those two types. Tell us about Crohn's disease first. What makes it unique?
Crohn's is tricky because it can affect any part of the GI tract, literally mouth to anus, anywhere. Though, interestingly, the rectum is often spared. Another key thing is that the inflammation goes deep through all layers of the intestinal wall.
Not just the lining.
No, transmural, we call it. And the inflammation isn't continuous. It happens in patches, a skip pattern, leaving healthy areas in between. This can give the inside of the bowel a cobblestone appearance.
Cobblestone. Okay. And the main symptom?
Often, it's RLQ, right, lower quadrant pain. But the key is that it's usually not relieved by having a bowel movement. That lack of relief is a significant clue for Crohn's.
Interesting. How is it managed during a flare-up?
Sometimes during a really bad flare, food might be withheld completely to rest the bowel. Nutrition might be given intravenously, that's TPN, total parenteral nutrition, or through a special, easily digested liquid called an elemental diet.
And surgery. Can it cure Crohn's?
This is critical. Surgery does not cure Crohn's disease. It might be needed for complications like blockages or fistulas, but the disease itself can, and often does, recur elsewhere in the GI tract later on.
Okay, no cure with surgery for Crohn's. What about the other main type, ulcerative colitis, UC? How is that different?
UC is quite distinct. It almost always affects only the large bowel and usually starts in the rectum, spreading upwards.
So just the large intestine?
Primarily, yes.
Yeah.
And it only affects the inner layers, the mucosa and submucosa, not the full thickness like Crohn's. Also, unlike Crohn's skip lesions, the inflammation in UC is continuous. No healthy patches in the affected area.
Continuous inflammation, what does that look like?
It can lead to a colon that looks very raw, inflamed, sometimes described as looking like raw hamburger. The colon can also become rigid and shortened over time.
And the symptoms?
The hallmark is often diarrhea, but specifically, stool frequently contains blood, mucus, and pus. In severe cases, you could be looking at 6 to 10 bloody stools a day. And the cramping is typically in the LLQ, left lower quadrant, unlike the ROQ pain often seen in Crohn's.
LLQ cramping, bloody stool. Okay, now the big question. What about surgery for UC?
Here's the major difference. Total proctocolectomy with an ileoanal pouch IS. A curative surgery for ulcerative colitis.
Curative? Really?
Yes. Removing the entire colon and rectum eliminates the diseased tissue and therefore cures the UC.
That's a huge difference from Crohn's. Any general care points for both IBD types?
Definitely. Allowing for adequate rest periods is important, working on dietary modifications, avoiding known irritants, and crucially, because of the chronic inflammation, there's an increased risk of colon cancer. So regular colon cancer screening with biopsies, usually every 1-2 years, starting about 7 to 8 years after diagnosis, is vital.
Wow. We have certainly journeyed through an incredible range of conditions today, haven't we? Right from the top down.
We really have.
From those distinct pain patterns in PUD, the vital dietary rules for celiac, the very specific signs of pyloric stenosis, to the really profound differences between Crohn's and UC, it just highlights how varied these conditions are and how much they can impact someone's life.
Absolutely. And what's truly remarkable, I think, is seeing how deeply our digestive health connects to our overall well-being. You know, if you think about the bigger picture,
Yeah.
well, while all these conditions are distinct, they often showcase the same basic principles, right? Principles of biological balance, how the body tries to maintain it, and how it signals when things are off. Thinking about how the body adapts or shows distress through these different symptoms, it just hammers home how interconnected everything is. Understanding these specific challenges really helps us appreciate the complexity of the whole system.
That's a great way to put it. It leaves you wondering, what surprising connection, or maybe what single symptom we talked about, will you now look at differently after our deep dive today?